Postoperative apnea or prolonged apnea is either due to central causes or peripheral causes. The central causes of prolonged apnea are hypocarbia due to intraoperative hyperventilation, thus removing the stimulus for respiration, which is the carbon dioxide. Other causes are opioids, either administered parenterally or during central neuraxial blockade. Rarely, it is related to accidents as a stroke and head injury. The peripheral causes of prolonged apnea are related to the neuromuscular junction or the use of muscle relaxants. It is either due to succinyl choline apnea or due to non-depolarizing muscle blockade. As regards the succinyl choline apnea, the block is either depolarizing type of block whatever the cause, or such depolarizing block may be transformed or converted to non-depolarizing block, a phenomenon known as dual block or second phase block. And it is due to the exposure of the motor end plate to prolonged depolarization, either due to the deficiency of pseudoclean esterase producing prolonged blockade, or due to repeated administration of succinyl choline, or even its infusion, although this practice is not used nowadays. Regarding the non-depolarizing muscle relaxants, it's either due to the use of overdose of the relaxant or a relative overdose, in which case we use usual dose, but there's a problem, the patient either a disease or a disturbance, other causes as we shall see. These are the causes that augment the muscle relaxants. Renal failure, hepatobiliary disease, anesthetics, mainly inhalation anesthetics, hypothermia, drugs which include antibiotics, magnesium sulfate, local anesthetics, antiarrhythmics including calcium channel blockers and beta blockers, and the obsolete drug nadine, dantrolene, and furosemide. Other causes that augment the muscle relaxants are acid-base status, electrolyte imbalance, mainly hypokalemia and hypermagnesiemia, of course, myasthenia gravis, myasthenic syndrome, or what's called Don-Lambert syndrome, muscle dystrophy, familial periodic paralysis, upper motor neuron disease, Guillain-Barré syndrome, and finally, use of a combination of relaxants of different mechanisms of action. Or more precisely, different chemical groups. Now we'll give a brief account of each of these factors. First, inhalation anesthetics augment neuromuscular blockade in a dose-dependent fashion. Not all types of anesthetics enhance such blockade to the same extent. Isoflurane is the most potent one. At the same time, not all relaxants are affected to the same degree by the presence of volatile anesthetics. Pancuronium more than atracurium more than vicuronium. What are the mechanisms by which inhaled anesthetics augment neuromuscular blockade? There are several proposed mechanisms, which are increase in the muscle blood flow, maybe CNS action, maintain the release of acetylcholine from the motor nerve terminal, decrease sensitivity of the post-junctional membrane to depolarization, direct action on the muscle membrane, and it's been noted there is no demonstrable effect on the cholinergic receptors themselves. The antibiotics, aminoglycosides antibiotics, polymyxins, colistin, tetracycline, lincosin, and clindamycins are the antibiotics that potentiate non-depolarizing neuromuscular blockade. The possible mechanisms are magnesium-like depression of the evoked release of acetylcholine, decreased sensitivity of the nicotinic receptors, and finally, channel blockade. And this explains why it's difficulty to reverse neuromuscular blockade with the use of antibiotics with histamine. The treatment, as we said before, there is some of resistance to such reversal, so we may use the maximum dose of histamine, which is 5 milligram for 70 kilogram weight patient. Calcium is not recommended for two reasons. First, the antagonism produced is not sustained because calcium and anticholinesterase may theoretically increase the channel block by increasing the activation of receptors. At the same time, calcium may antagonize the antibacterial effect of these antibiotics. Local anesthetics potentiate both types of relaxants. Being fast sodium channel blockers, local anesthetics may depress the propagation of nerve impulses. Other possible mechanisms of such potentiation are decrease of acetylcholine release, maybe a direct effect on the muscle membrane, or displacement of the calcium through the sarcolemma, decreased sensitivity of postsynaptic membrane to acetylcholine, and finally, procaine inhibits plasma cholinesterase and may augment the effect of succinylcholine. Quinidine is an obsolete antiarrhythmic. It's not used nowadays. It potentiates both types of relaxants by acting with the pre-junctional membrane. Zirconium is effective in antagonizing a non-depolarizing block produced by quinidine. In non-clinical doses, quinidine produces a depolarizing type of blockade. The neuromuscular block is potentiated by idurfonium. The calcium channel blockers They produce no block of neuromuscular transmission in clinical doses, but they potentiate non-depolarizing muscle relaxants, and occasionally they may produce difficulty in the reversal with nystigmine. However, this is only important if the margin of safety of the neuromuscular junction is reduced. The site of action is pre- and post-junctional, but it differs between drugs. I mean, differ between verapamil, for example, and nifedipine. The beta blockers, the most popular beta blocker used intraoperatively is the esmolol, which is used to treat hypertension and tachycardia and to prevent them. It has a minimal partial agonist activity or direct membrane depressant activity, leading to prolonged action of non-depolarizing relaxants. In addition, the catecholamine released intraoperatively will potentiate the effect of non-depolarizing muscle relaxants by membrane stabilizing effects. Magnesium is used as a magnesium sulfate in the treatment of preeclampsia. Eclampsia. It's well known to enhance both types of muscle relaxants by reducing the acetylcholine output from the motor nerve terminal and by reducing the sensitivity of the post-junctional membrane to acetylcholine and by inhibiting plasma choline esterase. And this last mechanism applies only to succinylcholine potentiation. The calcium. Calcium stabilizes post-junctional membrane, and that's why it partially antagonizes magnesium non-depolarizing relaxant-induced blockade. It enhances the release of acetylcholine from the motor nerve terminal and enhances excitation-contraction coupling in muscle. Its level is not of great concern clinically regarding the potentiation of muscle relaxants because muscle contraction is relatively independent on extracellular calcium concentration but on intracellular calcium concentration. Dantrolene, the drug used in the treatment of malignant hyperthermia, enhance non-depolarizing muscle relaxants by depressing skeletal muscle directly and block excitation contraction coupling. Furosemide loop diuretics enhance neuromuscular blockade by inhibiting cyclic AMP, decreasing energy production and decrease output transmission. On the other hand, mannitol has no effect on neuromuscular blockade. It is to be noted that the increase in urine output by mannitol with other osmotic or tubular diuretics has no effect on muscle relaxant elimination. Now I'm going to explain why osmotic diuretics as mannitol has no effect on relaxant elimination. Urinary excretion of all long-acting relaxants depends primarily on glomerular filtration. Mannitol is an osmotic diuretic, exerting its effect by altering the osmotic gradient within the proximal tubules, so that water is retained within the tubules. Thus, an increase in the urine volume in patients with adequate glomerular filtration would not be expected to increase excretion. Anticholinergics, succinylcholine and beta-curium, are theoretically prolonged by organophosphatidepesticides, cyclophosphamide, and equithiophate eye drops by causing significant decrease in plasma choline esterase activity. Acid-base status, respiratory acidosis in particular, and metabolic alkalosis augment non-depolarizing neuromuscular blockade, but more importantly, they limit and prevent their antagonism. How can pH influence the neuromuscular transmission? This may be obtained through membrane conduction or muscle contractility, or by affecting or changing the ratio of intracellular to extracellular potassium ions. It may affect the binding properties of acetylcholine receptors, or may affect the affinity of the muscle relaxants for the receptors itself. Impaired reversal may be related to the depressed muscle contractility rather than failure of transmission. Hypokalemia, both acute and chronic hypokalemia, will enhance the block from non-depolarizing muscle relaxants and diminish their ability to be reversed. The decrease in extracellular potassium will cause hyperpolarization and increased resistance to depolarization. In chronic diseases, both intracellular and extracellular potassium decrease without affecting such transmembrane potential, and it's expected that the response to relaxants and antagonism is normal. However, the muscle transmembrane potentials are changed in the severely ill patients or bedridden patients. In addition, severe dehydration will concentrate the relaxants in the plasma and increase its activity. In myasthenia gravis, there is sensitivity, or marked sensitivity to non-depolarizing muscle relaxants and resistant to succinylcholine, and you have good response to anticholinergics. However, in Eaton-Lambert syndrome, which is a syndrome encountered in patients with small cell carcinoma in the lung, about half of the cases, in many other cases, more than 50%, the cause is unknown. Anyhow, these patients are sensitive to both types of relaxants, either depolarizing and non-depolarizing muscle relaxants. And contrary to myasthenia gravis, there is poor response to anticholinergics, but they may respond to 4-aminopyridine drug stimulates the presynaptic release of acetylcholine. Myotonia, muscle dystrophy, the normal response to non-depolarizing relaxants, and the reversal of muscle relaxant can precipitate muscle contraction by facilitating depolarizing of neuromuscular junction. In muscle dystrophy, apart from the risk of exaggerated release of succinyl potassium with use of succinylcholine, the use of non-depolarizing muscle relaxants will be associated with prolonged response due to the presence of severe muscle weakness, though we may get a normal response. Patients with familial periodic paralysis may be sensitive to non-depolarizing relaxants, and it's better to avoid SUCs in these patients because it changes the potassium level. Patients with upper and lower motor neuron disease with hyperkalemia or SUCs, there's increased response to non-depolarizing muscle blockade in upper motor neuron diseases, with resistance to the lower motor neuron due to the proliferation of acetylcholine receptors, as it occurs in muscle denervation due to peripheral nerve injury. In amyotrophic lateral sclerosis, a disease which affects both upper and lower motor neuron disease, there is hypersensitivity to non-depolarizing muscle relaxants. The use of peripheral nerve stimulator will be unreliable in upper motor neuron lesions. Monitoring of the unaffected limb or other confirmatory tests of neuromuscular blockade should be used. The use of combination of non-depolarizing muscle relaxants may produce more than additive effects, and this applies when we use two muscle relaxants of different structure, different action, because such potentiation is lacking in closely related compounds as vicuronium and pancuronium. What are the factors that interfere with the antagonism of non-depolarizing relaxants? I mean, factors which make the reversal difficult. First, we have to note on the mechanism of action of anticholine esterase, what's called choline esterase inhibitors, nustigmine, hydrophonium, and pyridostigmine, which antagonize the non-depolarizing relaxants by increasing the availability of acetylcholine at the muscle end plate. And this availability of acetylcholine is mainly obtained by inhibiting acetylcholine esterase. Other possible mechanisms are to increase the release of the transmitter to the nerve terminal or blocking of neural potassium channels. These are the factors which make reversal by anticholine esterases difficult. Depth of blockade, the type of antagonist administered, I mean hydrophonium, pyridostigmine, or nustigmine, the dose of antagonist, the concentration of the inhaled anesthetics and the type of reversal, the rate of clearance of the muscle relaxant, the acid-base status of the patient, the presence or absence of hypokalemia, and finally, administered drugs, namely magnesium sulfate, beta blockers, calcium channel blockers, local anesthetics, and antibiotics. Of course, reversal is difficult if you try to reverse during profound blockade of neuromuscular junction, so you have to wait until recovery begins. The antagonist itself administered hydrophonium more effective than nustigmine, more than pyridostigmine in order of rapidity during standard moderate blockade. However, Hydrophonium is not as effective as neostigmine during profound blockade of more than 90% twitch depression. The dose of antagonists, the maximum dose of neostigmine is 60-80 mic per kg, or around average 5 milligram for a 70 kilogram patient. When you exceed such a dose, no further antagonist is obtained. It may even produce a depolarizing type of blockade. It should be noted that although antagonist esterases begin to act rapidly after the administration, however, the maximum effect is reached within 6 to 10 minutes. The concentration in anesthetics, of course, would affect the reversal, so it should be eliminated before attempting such a reversal. The antagonist is more rapid with drugs or muscle relaxants with short half-life than those with prolonged half-life. The presence of respiratory acidosis and metabolic alkalosis will interfere with the reversal. Hypokalemia, as we said before, by hyperpolarizing the membrane, and will increase resistance to depolarization. And although it's not the case in chronic diseases, due to decrease of both intra and extracellular potassium, we may get difficulty in reversal because the transmembrane potential are changed in these patients. In addition, dehydration will concentrate the relaxants and increasing the muscle relaxant activity.